Good morning, Ada County. This is Steve Cole with Ada County Paramedics and our Education Department. And whether you're part of Ada County Paramedics or one of our access agencies, I hope that this next little video is useful to you. So this is just going to be the latest version of my ongoing efforts to improve our basic airway management. By basic, please don't think that this does not apply to you as a paramedic if you're a paramedic or an advanced EMT. Hopefully there's going to be some stuff for everybody in here. Now, I'm not here to preach about to you, but I am here to give you a lot more tools in your toolbox so that when you open up your brain on that call, it's kind of like this. You're able to choose whatever tool you need to slay the monster that is in front of you. And by monster, I mean, the monsters of hypoxia, hypercarbia, and of course, acidosis and such. So that's what we're going to be talking about. Now, some of the things we're going to talk about, and chances are if you've sat through some of my lectures before, you've seen this. We discussed a lot of these about 18 months ago when we did our last big airway rollout. And we're going to talk about it again because 18 months is entirely too long. We're going to talk about better positioning, oxygenation. We're going to talk about face mask seal again, talking about ventilation planning. And I'm also going to throw some blogs and podcasts at you. I think I actually have more than 5, but there you go. So we're going to really focus on a couple key terms here. Oxygenation, ventilation, and some subsets of oxygenation, pre-oxygenation, reoxygenation, and of course desaturation. But we'll get to those. Trust me. So first, let's talk about better positioning of your patient if you have to manage their airway. Let's talk about better positioning. And this is one that, honestly, I wasn't taught at all in paramedic school. I thought we were doing pretty good when they did this, when we took our mannequins, we took our dummies, we laid them flat because that was how we found our patients. Well, that may be how we find our patients, but this is actually a very disoptimal, a very non-optimal way to ventilate them. And we're going to talk about ways to fix that. So ideally, for best positioning, we want something called the sniffing position. I think the reason why we confuse the sniffing position with what we do is because we think the head tilt chin lift is enough. And in some cases, the head tilt chin lift can sometimes make things worse without everything else involved. So what we want to do is we want to get the ear canal on par with the sternal notch. We want the face parallel to the ceiling. And what this does is this takes the airway, and not just the airway, the oropharynx, but the oropharynx, the hypopharynx, and the laryngeal airway, and takes out a lot of the 90-degree angles that are involved. By straightening them out, it actually allows for better airflow. And by allowing for better airflow, that's less turbulent airflow at lower airway pressures, which means we can move air in and out with less gastric distension. Now this also, as I'm going to talk about this, the optimal method for preparing the patient for intubation, but we'll talk about that. Now when we talk about patients who are morbidly obese, you think, wow, they're going to be really hard to get in this position because they just have extra tissue everywhere. But here's a prime example. And in fact, for the morbidly obese, this is almost essential to be able to oxygenate them. Otherwise, their airway is going to be so out of whack that it's going to be really hard to move air where you need it. The air will want to go into the gastric space, and that's going to be bad. So again, we have ear to sternal notch, we have head elevation, and we have ramping. And just drew a line right through there. Hopefully this works. Ear to sternal notch. The head is elevated. In this ramping, this could be towels. This could be, depending on how big they are, this could be, I don't know if I'd use pillows, but as you see here, bath blankets, pillows are a little bit too soft. This could be a really thin bag. This could even, in theory, be the O2 roll with a blanket, or the O2 tank with a blanket over it. Just depends on the exact anatomy and what you're dealing with. Something else we very seldom do is we elevate the trunk. Now there is a ton of research coming out on this, or I should say ton by a fair amount, a ton for what we normally deal with, showing that when you have somebody elevated at least 20 to 30 degrees, they breathe better, they ventilate better, the blood flows through the capillary beds of the pulmonary tract better, and gas exchanges better. So if we can raise somebody up, whether it's on the cot or whatever, 23 degrees, and I know that's not always going to be possible, while we're doing everything else, we're going to oxygenate better, and it's going to make a huge difference. Now, this just isn't for adults. It is, of course, for kids also. So when we talk about kids, we're not necessarily talking about infants, but we're talking about the 8-year-old, the 7-year-old, the 12-year-old, depending on their size. So here you can see what happens when we have the kid flat, like we all train. The ear is well below the sternal notch. And notice also the jaw here is flexed forward, and this means that the airway is partially kinked and has to go out at a greater than 90 degrees just to move air. However, when we raise the ear to sternal notch, the acuity of the angle automatically resolves just by raising the head a couple inches. And this seems counterproductive because we are always taught to move this towel underneath the shoulders. Well, as you'll see, that is probably not the best thing to do for kids. Now, I'm not talking about infants. I want to stress that. We're not talking about infants. Now, you take this kid, you've raised their head. The ear is still at the level of the sternal notch. And now we've done our chin lift, our head tilt. Not supine, but up here. And now airflow is at a much less angle, a much less acute angle. Airflow is better. So I hope that makes sense. And I want to really stress this, that for newborns, for infants, say less than 1, 2, or 3 years of age, not the 6, 7, 8, 9-year-old, we still want the pillow or the towel roll or the PALS textbook, for all the good it's going to do, underneath the shoulders. That will allow us to still get approximate ear to sternal notch. That will allow us to get a less acute airflow angle and better airway management in the infant, in the newborn, in the preterm, and in the young toddler. And as I mentioned, this is not just BLS. This absolutely improves things from a paramedic point of view. As you can see here in this picture, we have our handy paramedic with an excellent view of the back of the guy's throat, but the trachea is over here. And what this means is, at best, we catch just the bottom third or so of the trachea in our view. That's not ideal. We want a better view. So by elevating ear to sternal notch, we now have a better view straight down the trachea, and maybe if we're really careful, we can get eye on the carina. I don't know. I might be exaggerating a little bit, but you get the idea. In a perfect world, you can look straight through from here, straight out his colon. That would be perfect. So how do we do this in a pre-hospital setting? Well, this is where life gets interesting. In the pre-hospital setting, we don't always have a nice, pretty operating room with plenty of help. And I really need to get this picture updated to reflect use of our gurney, but I think the same principle applies. In this particular picture, we move the patient. Imagine this is our striker, our gurney, and just to give you an idea, the gurney would have the O2 tank roll here and the rest of the bed here. So we move the patient up, as we see here, drop her head back, and then we raise the head up, and you can see now we have ear to sternal notch. And the head is tilted up, so airflow is at a much less acute angle. Isn't that glorious? So that is better positioning. And if we can do that, oxygenation will improve. So let's talk about oxygenation. What makes for better oxygenation? Well, the first thing we ask is, what is pre-oxygenation? What is, if we say we're going to hyperventilate somebody, pre-oxygenate somebody, people have different perspectives of what that is. And chances are, if you're in EMT school or medic school, you just thought, okay, I got pre-oxygenate, okay, 6 breaths, boom, we're done, we're moving on to the fun, cool stuff. So a little bit more, we want you to think a little bit more about it. So when we talk about respirations and we talk about oxygenation and we talk about ventilation, the idea of pre-oxygenation is that we get them up pre-oxygenated before apnea. We get them up to in excess of 94% before apnea. And the apneic period could be when we're going to suction them or when we're going to intubate them or whatever the case may be. We're going to get them up to as close to 100% as possible. Now, I want to stress that you're going to be hearing a lot of information on how oxygen is bad in cardiac, post-cardiac arrest. Too much oxygen is bad in stroke. Too much oxygen is bad here. Too much oxygen is bad there. This is not that situation. This is the critically unstable patient who keeps trying to desaturate without intervention. This is the patient that we're about to intubate or do another advanced airway maneuver. This is the patient who is unconscious and apneic and possibly in shock. This is a completely different ballgame. So what we want to do is get their SpO2 as close to 100% as possible in this case. Now a couple ways to do that, commonly accepted, is normally 3 minutes on well-fitted non-rebreather at flow rates in excess of 15 liters per minute, or 8 to 10 full inhalation exhalation breaths at 100% oxygen. Now, I don't know the last time I had a patient that was that critical, yet I was able to wait around for 3 minutes. I don't know the last time I had a patient who was that critical, who was able to take 8 or 10 full inhalation exhalation breaths on command. But we still need to be familiar with this because this informs us in what we can do. This gives us a basis of comparison with some methods that we're going to do in the pre-hospital setting. And the goal of what we're looking for, here is something called nitrogen washout. Nitrogen washout is basically removing all the nitrogen out of the atmosphere that's inside our body and then replacing that with oxygen too. So nitrogen washout is important. Now, when you talk about the non-rebreather, that's kind of our go-to for oxygenation. At least it always has been in the past. But I want you to remember that even the best fitting non-rebreather at typical pre-hospital flow rates only gives you 60 to 70% oxygen, or 0.6 to 0.7 FiO2. That's it. And that's really important to understand. In order to get close to 100% oxygenation, we need to run flow rates in excess of 30 liters per minute. This is well studied. We normally don't have that abundant of a supply of oxygen, and we normally don't have regulators that will get up that high. So that's something to keep in mind. I want you to remember. You also might see that on a question later. So, some basic things to keep in mind when we talk about nitrogen washout. Normal FiO2. FiO2 is just a different way of saying percentage of oxygen, fraction of inspired oxygen. Now, normally what we breathe in is 21 to 24% oxygen, and the rest is nitrogen and smog and whatever else. Well, that means it's 0.21 to 0.24 FiO2. That's all that is. When you move into the hospital, you see things expressed as FiO2 a lot more than you see as percentages. So, when you keep that in mind, something else I want you to remember is that the concept of dead airspace. Now, dead airspace is basically the air from the tip of your mouth to right outside the alveoli. So the dead airspace is approximately 150 cc's. Now, what that means is that is 150 cc's out of our total tidal volume of 600 to 800 cc's. that is basically a reservoir, just like the reservoir on the end of your BVM. Now it can be filled with 0.21 FiO2, 21% oxygen, or it can be filled with 100% oxygen. It can have about 30 to 40 cc's that's actually useful, or it can have a total of 150 cc's that is mostly useful. So what we're going to do is we're going to replace the inert gas, the nitrogen. We're going to replace it with as much oxygen as we can squeeze in there. And this washing out of the nitrogen, getting rid of it, is called nitrogen washout. And it basically creates an abundance of oxygen for us to use in times of crisis. Now, there's a little bit of nitrogen free floating in the plasma, but it only amounts to about 5% when we replace that 5% increase in available oxygenation, where dead air space is significantly more. So that's what we're going to focus on. Now, it's important to note, it's very important to note that without pre-oxygenation, an SpO2 greater than 94% is nothing. They can still crash, and this is well studied, they can still crash in under 2 minutes. In some cases, 30 seconds or less. So even if you have a patient who's walking around with an SpO2 of 96, 98% because they have healthy lungs, so on and so forth, when you make them apneic, they will start to desaturate quickly in just a couple minutes. That is why pre-oxygenation is so important, is it builds up the reservoir they don't normally have. And it prevents horrible crashes like this from happening before we have a chance to do something about it. So this leads us to a concept called safe apnea. And safe apnea is essentially the time it takes them to desaturate to 88 to 90%. I say 88 to 90%. For this, we're saying 90%. But some texts, some articles you read say 88%. 88 to 90%. The time from when apnea starts to the time when they desaturate to that. Because 90% is our oh my God mark. 90%. And here's why. If you look here, this, let me get my right highlighter here. This is oxygen saturation, what we normally call SpO2. And that is, let me highlight this for you so everybody sees that. This is, now this assumes that we have a good SpO2 reading. If you have a crappy placement on your SpO2, if their hands are cold, this will not be reliable, and you need to consider that. So, when you look at this, here's 90%, right? And this little thing, this is called PO2. This is arterial oxygenation, and this is not in percentage, not percentage. Excuse my horrible writing with the mouse. Not percentage. This is very important because this can get up to all the way up to 400, 500 millimeters of mercury. We'll say 400 just because I feel like writing that. Okay, let's get up to 400. So, but this will only be 100. It'll never get higher than 100. Okay, so this line right here, this is what we call the oxygen hemoglobin saturation curve. So, at 90%, what this means is that when we hit 90, we are flirting, and I don't even say we're flirting, we are at hypoxemia. When we are at 90, it's going to be about 94, 95%, we are at hypoxia. Now, this assumes that we have a normal body temperature because body temperature will shift this curve depending on whether we're hyperthermic or hypothermic, either way. But for simplicity, this is 90, we'll say 94, 94, and this is 90. And the reason this is bad is hypoxemia, or we start having really bad stuff happens. We start having cardiovascular collapse. We're flirting with cardiac arrest. We're flirting with anoxic injury. Lots of other stuff that we really, really, really don't want to have happen. Absolutely don't want to have happen. So the idea is, if this area, we need to start intervening so that we stay up here. And this is what we call preventing desaturation, is when we keep them out of here and we move the patient up there. So excuse my scribbles. So when we talk about desaturation, as I just said, desaturation is defined as saturations below 90%. Now we know that normally a person with a room air saturation going into an apneic period, room air saturation of greater than 94%, will have a safe apneic period of about a minute. If we can turn that around though, and we make that their room air saturation of greater than 94% on high flow oxygen, washout nitrogen, we can extend that out to 8 minutes. Out to 8 minutes. There are some times, though, that we can make that even longer. But think about that, 8 minutes. What could we do in 8 minutes? We could take our time bagging, we could take our time intubating them hopefully without adverse effect, without desaturation. And if we can take our time, that means we can be more successful. We can be more diligent. We can have less bad effects. Now, the only problem with this is something called physiological shunt. And physiological shunt is any physiology preventing us of getting their saturations up despite aggressive pre-oxygenation. Now, Scott Wingart, who is one of the luminaries in this, just put it very succinctly, is their lungs are filled with crap. This could be blood, this could be pulmonary edema, this could be pneumonia. But one thing he didn't mention is it could also be poor pulmonary blood flow, like you see with PE. But something that is inhibiting gas exchange. Sick lungs usually. Shocky patients, whatever. But it's the ability to pre-oxygenate above 94, 96%, despite high flow oxygen, the nasal cannula, and all the stuff we're going to talk about. If you find this is the case, that's a huge red flag that something bad is going to happen. So we'll say that we are putting them on the non-rebreather or putting them on the high flow nasal cannula for up to 3 minutes while we're getting other stuff together, and they still won't saturate up to 2 minutes. They still won't saturate up. What do? Well, we can throw pressure in there, and that pressure is CPAP, or it's PEEP on a BVM, or it's the BVM with the nasal cannula flowing as well, which will kind of give us a poor man's PEEP and a poor man's CPAP. So adding pressure, it will pop open alveoli, give us more surface area to deal with, and hopefully improve oxygenation. And if they won't oxygenate with that, then we're in real trouble. So the question is, we'll say that once we enter an apneic period, how quickly will they desaturate, even with good oxygenation? And the answer is anywhere between 0 and 8 minutes. And there are some things we know that will predict that. You may see this again, but just to highlight this is a patient. If you see here, this is their pulse ox. And these 3 patients, 1, 2, 3, these 3 patients are right about 98, 99% with pre-oxygenation. So we bagged them up, or we put them on a non-rebreather, we put them on a cannula, and we got their sats above 98%. Now, the one who did the best, predictably, is the healthy male, and he made it almost 10 minutes till bad things happen. But he started desaturating. We'll say that our magic number, it's going to be right about here. This is going to be about 93, 94. And he made that right about 8 minutes. Make sense? And this is a normal 70 kilograms, that's about 150 pounds adult without any bad stuff going on. This particular patient, same weight, but he's moderately ill. And we don't know exactly why they're moderately ill, but they couldn't get their SATs above 94%. Here they are, despite everything we're doing, and we do good. We still do the best we can, and they DESAT right about 4.5 minutes. 4 minutes, 4.5 minutes, somewhere in that ballpark. Okay. Well, kids, we know kids don't tolerate hypoxias. Well, how quickly are they? Well, here's a kid who's healthy, 98%, comes around, and he desaturates, hits the 90% mark right about 3.5 minutes. Now, again, this is not the kid walking down the road. This is the kid that we've pre-oxygenated aggressively before this. 3.5 minutes of apnea. That's still a lot of time. And then we have this guy. This is the healthy, if you want to call it that, obese guy. This is about 250 pounds. And we know that we've seen a lot who are a lot bigger than that. And he hits 90 right about here, right about 2.5 minutes. Quicker than the healthy adult, quicker than the sick adult, quicker than the kid. So what this tells us is the obese patient is the ones that we have to watch out as much or more than even the children. Not that we won't pay attention to children. So again, excuse my scribbles. Now this is with apnea. But what if I told you that we could take that safe apnea period and we could basically oxygenate them even when they're not moving air, even when they're not breathing? And what if I told you that we could do that for up to an hour, 60 minutes? In the resources tab, you'll find the actual foundational research for this. 60 minutes. Think about that. Now, we will never do that. I'm not suggesting that we would. What this illustrates is the time that it takes and what we can benefit with by doing some of these procedures. And one of the big things, something that's called, that we call no DESAT or apneic oxygenation. No DESAT is an acronym that stands for nasal oxygenation during efforts to secure a tube, and that's commonly what's known by. But we're seeing a shift of people starting to call it apneic oxygenation because that better reflects what it is. Because apneic oxygenation doesn't have to occur during intubation. It can occur during a lot of other events that involve apnea or near apnea. It doesn't have to be with intubation. So here's how this works. So essentially, this is the alveoli. I think everybody gets that. And the question is, how fast is oxygen, and why oxygen is red instead of blue, I don't know. But oxygen is shooting across the capillary bed at about 250 milliliters a minute. Now, this is assuming that we have good blood flow through here. But CO2 is only hopping back at about 2 to 10 liters per minute. This is a lot less, and this creates a deficit of 240. So where does that extra 240 milliliters comes from? Well, if this is the alveoli, and this is the alveolar duct, then what's over here? And the answer is the lower airways. The bronchial tree, the hypopharynx, the trachea, the bronchioles, everything that is what we call dead air space. And that is about, if you remember right from earlier, 150 cc's. So if we have this 150 cc's of high concentration oxygen, then this deficit is going to keep pulling oxygen in like a vacuum and help allow continued oxygenation even though they're not breathing. Now CO2 will still build up because we're not ventilating, which is why if we can give a couple breaths every so often to wash that out, that's ideal, but not necessary. We can oxygenate them for up to, are you ready for this? Up to over 100 minutes. Up to 100 minutes has been done. in volunteers. Now, we will never do that. I want to stress that. That's not our goal. But that shows you the time that this buys us. But the key is we got to have the nasal cannula running at a far higher than what we ever did before. And that's in excess 15 liters per minute. Now, we can do this a whole bunch of different ways. We can run it with the nasal cannula and the non-rebreather. We will also do this with the BVM. And the key thing is that when we stop all this and we start to intubate, we still have the nasal cannula running the whole time, so airflow continues while we're intubating. Does that make sense? I hope it certainly does. So as I said, how long can this be done? Well, at least 100 minutes. We'll never do that, but this is not just Steve Cole speaking. This has been studied extensively, and what's really neat is it's been going on since the 50s. And the question is, well, do you need to bag at all? And the answer is it depends. The problem is that there's twofold issues. On one side, bagging is good because it washes out CO2. Bagging is good because it increases airway pressures a little bit, so we get a little bit of oxygenation. The downside is it also increases the chance of vomiting. And vomiting has a very high mortality. So as a general rule, if we can oxygenate them without overventilating, we certainly will. And as I said before, if you can throw a nasal cannula on a patient, but you don't position them right, you won't get airflow and washing out nitrogen where you need it. Apneic oxygenation works best when you have them positioned, ramped up, 20 degrees, head tilted back, and ear to sternal notch in that sniffing position. So the question is, if we don't want to ventilate them, if we don't want to use the BVM, at what time do we say we need to ventilate? And the answer is when you see their SATs drop below 93%, we need to reoxygenate. So with the BVM or nasal cannula in place, we will then give them some breaths as gentle as possible to get their SATs back up to close to 100%. Because remember, the more we ventilate, the greater the chance of vomiting. So we will ventilate only when their SATs drop below 93%. Now, when we talk about ventilation, I can't stress this enough. We need an outstanding face mask seal. So you may have seen this before. We'll talk about this in training also. Getting a face mask seal can be difficult. One of the biggest ones, patients that may give us problems with face mask seal are those without teeth. And so if we have a patient, a little old lady that has left her dentures on the bedside when she coded, and our traditional face mask seal is not working, then bring the face mask seal off the chin. The gums are here. And then, of course, this moves this up just a little bit to the bridge of the nose and try ventilating that way. The other thing, and I think this is most important, is I don't want you to ventilate using one-handed if you can at all possibly help it. In every case, two-handed technique has proven superior to one-handed technique time and time again. Now, let me give you an example of this. In this next picture, you're going to see my daughter. And my daughter, right there, as you can see, is able to get good face mask seal. She's 7 years old here. And as you can see, she's still able to do it. So let's see if this plays.
What are you doing with your hands? Okay. How often do we do it? How often though? And how fast? Yeah. Okay. How many hours do you do?
So I'm going to stop us right there, and I hope you were able to catch that. It's not just important to get air in and out, but you have to watch your airway pressures. We want two-handed face mask seal, which you see here, and gentle ventilation. And if my 7-year-old daughter gets this, I hope every one of you can as well. Now, for those with small hands, now she's doing the EC technique and she's able to make this work. But honestly, the TE technique has been proven to be better, especially for those small hands, less fatiguing and better face mask seal. So the TE references something called the thenar eminence, which is the thumb pad. So you're using that to press down to get 360-degree face mask seal. And instead of pushing down on the jaw, you're actually pulling up against the mask. And that enables you to rock the head back and get better airway position. And again, in every study, every single study, two-handed technique is superior to one-handed. So the question is, what if I'm the only one on the airway? We only have 2-man units, somebody needs to do CPR, something like that. Well, even if you're on Mount Everest here, I would rather you get the abominable snowman to squeeze the bag while you get a face mask seal with 2 hands than to do it one-handed. I would rather you get Bubba the bartender than to try one-handed face mask seal. But we'll say that you absolutely have no other choice. Oh, it didn't show. Then you do what you gotta do. Now, something else to keep in mind, we talk about different devices. Don't forget the new mask is an option. If you're by yourself, you can get a face mask seal with the new mask with one hand. Also works good if you have beards. Nice little, does come in CPR mode. Something else is if you can't get a good face mask seal, consider a PD mask on the nose and closing the mouth. Now this also illustrates something else I think that's pretty important. We underestimate the advantages of a well-placed MPA and OPA. This area back here, this is often compressed and means we will get less airflow if we don't use an OPA and an MPA. Now, as a matter of fact, I want you to use both, but we'll talk about that. You know, if only we had a face mask seal like this for those of you guys who are Alien fans out there. All right, so let's talk about better ventilation. We talked about getting good face mask seal. We talked about oxygenation in. We need to get air out. So key points about ventilation is we just want to get enough air in to make the chest rise. That is our key criteria, especially if you have a nasal cannula flowing at 15 liters per minute. Especially if you have a nasal cannula flowing at 15 liters per minute. Just getting air in, chest rise and fall is all you need to oxygenate and ventilate them. Now, normally we're breathing 6 to 8 liters per minute, or milliliters per kilogram, which is about 5 to 8 milliliters. Correction, 500 to 800 milliliters. Now, if you think about this, our BVM, some of them can be 1,000, some can be 1,200, even up to 1,700 milliliters. We do not need to squeeze the whole BVM in. We only want to use one hand, and that's it. We do not want to over squeeze. And when we talk about using MPAs, it's important to have a properly sized MPA and OPA. You can see right down here, this undersized OPA is not keeping this lumen open, where this properly sized one is keeping the tongue out of the way and allowing for better airflow. And the MPA is also equally important because an MPA should move right past this barrier right here and end up right down here to allow airflow, which is why we actually recommend not just an MPA, not just an OPA, but we want both an OPA and 2 MPAs. I know I talked about this a couple years ago, and this is ideal if you have the right sizes. That's another example of what it might look like. Also, we want you to monitor airway pressures, and these are available for those of you at Boise Fire and Meridian Fire. If you don't have these in your kits, order them through our supply. We'll get them to you. Everybody at Ada County, these should be in the orange bags in the primary jump bag. Use them every time you use a BVM, please. And those of you guys at the fire agencies, if you forget them, we have them in our kits. Please ask for them when we show up on scene. We want to keep airway pressures less than 25 centimeters of water. And the reason is that's what it takes to pop over the gastric sphincter, what we call the cardiac sphincter, and shove air in the stomach. If we can keep airflow less than that, then we dramatically decrease the chance of vomiting. Now, it's important to remember that if they vomit their gastric contents, that leads to a specific type of aspiration pneumonia that has a 40 to 70% mortality. That means on top of everything else, they have a 40 to 70% chance of dying if they vomit and suck it in their stomach. So, we do not want you to commit first-degree BVM homicide by overventilating the patient. Okay? So we're wrapping up here, and we're going to talk about a couple final things. And this is directed strongly at the ALS providers, so if you're listening to this, please perk up, but also to the BLS providers. It's not enough to just show up and stick a bag or a nasal on somebody and think it's going to work. You need to have a plan. You need to have a plan for the next step you're going to if whatever you're doing is not working, and also you need to have a plan that is communicated to everybody. And there are all sorts of plans. This is one airway management chart from one hospital. They have a plan A, plan B, plan C, and plan D. And they give you the different options. They also, this is from Cali Shock Trauma, of those of you guys who know that. This is their airway plan, where they go through laryngoscopy. They intubate once or twice, or perhaps even 3 times in the worst case. But if at any time the patient desaturates, they jump straight to surgical airways. Now, we're not quite that aggressive here. They're a little bit different situation. They're dealing with the sickest of the sick, and they're specifically dealing with trauma. We're talking about trauma and medical. But the point is they have a plan, and everybody in that trauma bay knows it. Everybody in the trauma bay knows that if their SpO2 drops 93% at any point, they do face mask and OPA or SGA, and if that doesn't work, they progress to surgical airways very rapidly. This is another airway plan by Wingard. And here's another one that we're looking at. Again, you see a very simplistic A, B, C approach, and then you move on. And if everybody understands it, everybody has a common strategy. So whether you're dealing with the brand new medic or the senior medic, if everybody's on the same page of music, and the BLS providers, that's going to reduce a lot of problems. Now, finally, I'm going to talk about checklists. I'm not going to spend a lot of time on this. You may see us move to some checklists in the future. The only thing I want to say about this is checklists are not procedural checklists. They're oh crap checklists. Like what we see in the Miracle on the Hudson, when Captain Sullenberger landed an aircraft in very short notice. Now, a lot of people say, I don't have time for checklists. I would say that if he can land somebody in under 180 seconds, and save 130, 150 lives, 120 lives, then we can use a checklist to help make sure we don't make a simple but critical mistake. Now, as I said, that these aren't procedural step-by-step checklists. They're oh crap checklists. They're not protocols. They're not teaching tools. They're not credentialing like a National Registry skill sheet. They're just red label items. They're stuff that you absolutely have to get. And they aren't just a checklist. They're usually challenge and response. So you verbalize it, and then somebody makes sure you actually did it instead of verbalizing it. And they're team-driven, and they're tested. They're not just created in a desk. They're practiced, and the bugs are worked out. And the first rule checklist are do the job. Aviation checklist, you'll see a lot of first rules, fly the plane, so that you don't forget to fly the plane while you're doing the checklist. For us, it'd be the equivalent of manage the ABCs while you solve this. And it seems like a no-brainer, but humans are funny creatures when they're under stress. Our brains do funny things. Lots of other things. You see, this is actually a layout that they use in Australia, New Zealand, and some services, and they have their checklist right over there. There's an example of it in use. This is another one, very similar. There's actually a cardiac arrest checklist. This is in use in Hilton Head Fire and Rescue. A checklist for making a checklist to make sure you don't make it overcomplicated. And if you want to know more about any of the stuff we've talked about here today, whether you want to know more about checklist, or you want to know more about apneic oxygenation or better ventilation, or just almost any topic you can imagine, these are some great resources. Pause the video, write them down. Some of these are higher end with some pretty advanced topics, and some of them absolutely can be understood by a first responder in the most rural location who hasn't had a lot of exposure to medicine, and everything in between. So I always put this out there because all these are free. All these are free, so please feel free to take advantage of them. And that's pretty much it. I want to thank you, and I hope you had a good time listening. I hope you refreshed your brain. And that's pretty much it. Thank you.